Okay. So, good morning to one and all
Can
gathered
you hear me
here.
now?
Yes, sir. Yes. Yes, sir. Arul, sir, can you have a voice check, please?
Yeah, sure. Am I
Yeah.
audible?
Yes, sir. Thank you. Dr. Usaid? Okay. So, good morning to one and all gathered here for today's online webinar on obsessive compulsive spectrum disorder. So, in this era of pandemic, hand washing has become a norm more than a disorder. But it is always more difficult for people who has obsessive compulsive disorder to manage these issues, and it gets escalated during these kind of time where continuously they think about getting infected over and above other people. So this particular topic is of interest right now, so we have taken this particular topic for our CME. So welcome you all to today's CME, and I would like to call upon Professor Dr. T. Sivayalango, a professor and HOD, Karpagavinagar Institute of Medical Science, to present the welcome address. Over to you, sir.
Thank you, Arumugam. Very good morning to all. It's indeed a great pleasure and honor to welcome you all for this CME program conducted on behalf of Department of Psychiatry, Karpagavinagar Institute of Medical Sciences. Probably a lot of you know that we conduct this program every year in the month of May, but unfortunately this year due to the COVID-19 pandemic, we couldn't do it. But I'm glad somehow it's materialized now in the form of online platform. We are all getting used to the new normal, adapting to the challenges and post every day. I hope this endeavor is one such example. Like Arumugam said, the theme for the CME OC, obsessive compulsive spectrum disorder. So how we end up choosing this topic? Actually, to be honest, we had a few topics in mind, but a lot of you are aware that every day some kind of webinar is going around the corner, and we also have done a few CMEs earlier in our institute as well. So we kind of felt the obsessive compulsive spectrum disorders would be an ideal topic. And also in the context of pandemic, it's very difficult now to differentiate what is normal, what is not normal. So we thought, okay, let's deliberate on this topic and gather some knowledge so that people will be very much aware of what is going on. I remember very much, my professors used to say that people suffering from OCD, they are called silent sufferers. They don't come out very openly. They continue to suffer within themselves. I have seen patients like in the adolescence and adulthood, and when you actually dig the history, you will get either one of the parent or some family members have been suffering from the same illness, but without getting an attention of the mental health services. So such, it's just being kept very quietly within and suffered by the people. And there are a lot of people who think that it's embarrassing to talk about it, and sometimes it's been ignored by the families, and some people actually think that it's normal to be obsessed. And one may wonder, like, whether is it not a personality, having an obsession, or is it something like a disorder? Actually, when the symptoms are of such severity and intensity affecting one's daily functioning, we call them as a disorder. I just remember, like, when I say the word disorder, because once a patient was saying, yes, when we explained that you have, OCD, obsessive compulsive disorder, and the person was clearly saying that, no, how can I become, have disorder? I think all I have is in order in my life. So when I have everything in order, how can I get a disorder? So that was a funny paradox. And another person actually say, like, not to me, but that's a general, comment. Like, I can't have OCD. I have checked it, 50 times in the internet. It's not OCD. So such a kind of, interesting conversations we end up having with our patients. And definitely, like, I would like to recollect, whenever an article is being published about OCD in the newspaper on a weekend, either be in Hindu or in Indian Express, The next week, you will see influx of patients to the OPD. And then things normalize as usual. OCD is very challenging, particularly when it is recognized in children and adolescents. And definitely it's a common comorbidity among severe mental illness as well as in common mental disorder. It is one of the disorders where a lot of research has been done in connecting the various brain circuits and clinical symptoms. But still we end up having a lot of debate about their connections. So a potential area for learning for everyone, and certainly we have among us the experts in this area who are committed to share their experiences and guide us to negotiate the challenges posed in managing this disorder. I just want to briefly mention about the speakers. Dr. Arul Saravanan, who is the professor of psychiatry at SRM, who is interested in phenomenology, has vast teaching experience, is a soft-spoken but hard worker. Dr. Preeti from Madurai, I don't know her personally. I actually happened to know her through Dr. Jayantini, who I approached for this topic initially. And she said, like, I'm too old to, to do the kind of online stuff. And also, a lot of people have heard me, talk every in conferences and seminars. So you probably get new faces. And she recommended Dr. Preeti. So, and I heard from a lot of my colleagues that she's a very good speaker and she has spoken in many academic forums, particularly, about mental health issues in children. And Dr. Karthik, he is my contemporary. He is a very good clinician and a great academician. He has high regard among our own colleagues. He's a well-known person in Nottingham Mental Health NHS Trust. Actually, very few I know that who have decided to pursue psychiatry even from undergraduate years. And finally, Dr. Usaid, I'm sure a lot of our own undergraduate and postgraduates know how enthusiastic teacher he is. He's a very valuable asset to our department. So I feel very proud and privileged to have you all among us today to share your wisdom and to enrich our knowledge. I welcome you all, the speakers and the delegates, particularly the faculties, the postgraduates, the undergraduates from KIMS and other medical colleges across Tamil Nadu to this CME program. And I hope sincerely that you will be benefited by the end of this session. Once again, I welcome you all. I hand it over to Arumugam to start the session.
Yeah, thank you, sir. That was an excellent welcome address. In fact, a lot of being said, and that might be an eye-opener for everyone what is going to be expected in the forthcoming sessions. Regarding the topics per se, as you say, no subject is bad. It is only how we teach them or how we give the information transform into likableness or dislike. So we have to take us on OCD, right from the neurobiology to the treatment aspects. So first, I would like to welcome Professor Arul Saravanan, who has completed his undergraduation from the prestigious PhD Institute of Medical Science and Research Center and has done his post-graduation diploma training from Madras Medical Colleges and MD from Kasturba Medical College, Manipal Academy of Higher Sciences. He has special interest in forensic psychiatry and consultation licensed psychiatry and substance use disorders. Currently, sir is working as a professor in SRM Medical College and Research Center, Chengalpet districts. He is an author of various chapters, especially forensic aspects of mood disorders in the chapter of mood disorders today. And he has various publications in national and international journals. He has presented multiple times in conferences and is an executive member in the Chennai Psychiatric Society and is the associate editor of its newsletter. So to start with, I welcome Dr. Arul Saravanan, sir, for the topic. Before that, small information for the delegates. If you need to pose some questions to the panelists, will panels and important questions will be answered. If there are more questions, we'll try to accommodate all questions and try to answer to that question. Kindly specify your name and your place of study or practice in the question section and to whom you're willing to address the questions. Thank you. So over to you, sir, for the excellent presentation, or to the going to be an inspiring presentation on neurobiology of OCD and its clinical implications. Sir.
Thank you so much, sir.
Thank you, sir.
My special thanks to Professor Surveillance Bose, HOD of the department at Dr. Vinayaka Medical College. And thanks to Aranganathan for his introduction of me. Yeah, said so many nice words. Thank you once again. Without much ado, I would like to go into the presentation. The topic today is neurobiology of OCD and its clinical implications. Let me just share my PowerPoint. Is my PowerPoint visible, sir?
Yes, it's visible, sir.
Greetings from SRM Institute of Science and Technology, SRM Medical College, and the Department of Psychiatry. Thanks once again to Dr. Vinayaka Institute of Medical Science and Research Center, the department headed by Surveillance Bose. I would like to.
Login பண்ணவே இல்லையா? I just want to see delegates linkல எப்படி தெரியுதுன்னு.
Shall I proceed?
So you get வருதுல்ல?
Is everything set?
Sorry for the disturbance, sir. You're just checking with the delegate teams.
Sure.
Yes, sir, you can carry on, sir. Sorry for the disturbance.
Shall I go on?
Yes, sir, you can continue with your presentation, sir. Sorry for the disturbance. Thank you.
So I've divided this presentation into 3 parts. I understand there would be a mixture of participants in this webinar. We'll have first years, second years, and third years, and of course, our senior and junior colleagues. And in order to set the ball rolling, the first part would consist of introducing the topic per se. And I'll be concentrating on the second part, which is my topic proper, that is the neurobiology of OCD and related disorders. And the final part will touch upon the implications and the treatment aspect. And of course, that would be dealt by the speakers henceforth. So that would be very brief. So we'll start off with the introductory part. First and foremost is my interest is in phenomenology. Phenomenology is something with which we understand our patients, and that is very vital to our specialty per se, I would say. Irrespective of whether there is quite an advancement in technology and the way we investigate things and the way we assess and try to treat patients, the cornerstone of psychiatry has and shall remain as phenomenology. Take, for instances, take the recent example of COVID itself. Now, COVID can disrupt so many things and has disrupted so many things. And probably, if we do not have the luxury of investigative technologies, I'm sure we would have to fall back on your basic phenomenology, which will help us in order to identify the problems, share the problems with the patients, and will also help us to ensure an effective treatment for those problems. That's why I always insist to my postgraduates as well that phenomenology is something which you should have a good routine, regularly repeated behavior, and they require little or no practice, and it's rather learned rather than being innate. Whereas mannerisms are odd and stilted, purposive voluntary movements. The key word here is purposive, that they do not occur randomly, that the subjects or the patient have this as a purposive. Rituals are nothing but a sequence of activities performed in a special place or a sequestrated place and according to a set sequence. That can be anything, a ritual which you can do it either in the privacy of your bathroom, or it can be something which you do in a public place, like say for example in a temple or in a marriage. Okay, so such things are called rituals. And why are we dealing with this? I will come to that later on. Of course, you are aware of this formal definition of obsessions. Obsessions are recurrent, intrusive, ego-dystonic thoughts, images, impulses, ruminations, or fears, which the subject knows that are his own thoughts. He recognizes the frivolous nature of it, but has poor control over it, and those cause subjective distress in the patient. Now, compulsions are, some consider them as counterpart of obsessions. These are recurrent behaviors or acts or rituals done in association with obsessions. If you look at obsessions, irrespective of what the obsessions are, what you will find is that there are three essential key features in obsessions. Number one is a feeling of subjective compulsion. This is a sine qua non of OCD. Okay, and number two is the resistance to it. Often you find anxiety that predominates in obsession. Once the obsessions start to become, or once when the compulsions are rooting in the patient. And the third and most important thing is the preservation of insight. This will differentiate, will help us to differentiate between whether this is going to be in the proper OCD realm or is it going to be in a different spectrum altogether. Now, compulsions. Again, the key features which one has to look in, irrespective of the varied presentations of compulsion, is that there is a need to perform this behavior. And this is most often done to ward off the anxiety. And there is also the conflict that the person has to do it, preserving the social acceptability as well. Now, certain compulsions are initially, at least the patient tries to do it in private. That is when others are not looking at, and others are, when he is in his own private sphere. But as the compulsions progress, he finds it more and more difficult. And these compulsions also spill over and do occur in the public places and social areas as well. So that is something which is again going to be problematic. And these two are again key features which one has to look into. Apart from most often students are happy with finding the presentation of the compulsions. It would be good if they go back and look if these key features are there in both obsessions and compulsions. Now, once you group all these obsessions and compulsions, and the factor analytic studies were done, what we get is, in some studies we got 3 and few other studies and expanded 5 clusters. And these are, number 1 is aggressive and somatic cluster, number 2 is symmetry and exactness, number 3 the fear of contamination and illness, and 4 and 5 are hoarding and sexual and religious obsessions. And of course, each of these obsessions have their own counterpart compulsions. If it's fear of contamination, you have compulsions to ritualistically wash and keep on cleaning. If it's pathological doubt, you keep checking. And fear of causing harm brings about repeated checking, and so on and so forth. Now, the underlying factor in each of this, what researchers say is that there is this feeling or urge that there is something is wrong. This is something which is very key and which the patient is able to report. Something is off is what often the patient says, and he tries to understand this and he tries to correct it. Obsessions can also be conceptualized as an enduring perception of an error in specific instances that will invariably result in mounting anxiety. and compulsions being the behavioral, or sometimes they can be mental compulsions as well. Those mental responses that serve to reduce this anxiety. Of course, initially, this resulting anxiety-free state due to compulsions is rewarding. But because of its transient and short-lasting nature, it is often followed by an intrusive recurrence of obsessional state. Now, briefly, we'll look into the position of OCD in ICD-10 and the forthcoming ICD-11, and we'll compare with DSM-4 and DSM-5 as well. I'll just rush through this because, of course, this is something which is available and which I'm sure many of you have known by. Okay, in ICD-11, the changes that is brought is that now this is taken off from anxiety disorders, and probably they like to call it as obsessive compulsive and related disorders. Here again, what they emphasize on is that there should be an awareness of the silliness or the nonsensical character of these obsessions. And these should be non-bizarre, or most often that they are ordinary activities or tasks which the patient would be otherwise normally doing. And there will be marked cross-cultural consistency in the themes of their symptoms. This is something of interest, irrespective of where the patient is, whether he is in South India, North India, he is in India or abroad or in Western Hemisphere, Eastern, wherever the patient may be. What we find interestingly is that the presentation of the symptoms all fall into certain particular themes. Of course, you do have either obsessions or compulsions, or as we most often have, we can have mixed obsessive and compulsive presentations. Now, coming to DSM-4 and DSM-5 OCD disorder, of course, in DSM-5, the requirement of both obsessions and compulsions are retained. Now, I would like to just focus on what has been dropped from DSM-4. The thoughts, impulses, or images are not simply excessive worries about real-life problems. That clause in DSM-4 has been removed in DSM-5. And the criteria that the person recognizes that the obsessional thoughts, impulses, or images are a product of his or her own mind. This is with regard to the insight to the phenomenon. That has also been dropped in DSM-5. And of course, that the patient at some point during the course of the disorder must have recognized that the obsessions and compulsions are excessive or unreasonable has also been dropped. Now, DSM-5 has brought forth a few specifiers as well. Number one, with good or fair insight, with poor insight, with urgent, totally delusional beliefs, and of course, specify whether it is related to tics or otherwise. Now, coming to the epidemiology of OCD, according to the World Health Organization, OCD is the 6th most disabling pediatric disorders. We take the OCD invariably occurs within the first 10 of the most disabling psychiatric disorders all along. The ECA study reported a lifetime prevalence of OCD anywhere between 2 to 3%. And the National Comorbidity Survey Replication Study has also showed that the lifetime prevalence is about 2.3%. Somewhere it hovers around 2 to 3%. Again, one subset of interest is childhood OCD. And very few epidemiological studies have been done in India. And probably this is one area that postgraduates and junior colleagues can look into. Thankfully, Jayasurya et al. Have done their study from NIMHANS, and the prevalence of OCD has been reported to be at around 0.8%. What is of interest is that the age of onset is earlier in boys than in girls when it comes to childhood OCD. And often you find that there is a first peak around puberty and another peak in early adulthood. And of course, the comorbid conditions of childhood OCD would be depression, movement disorder, and anxiety disorders. Just brief comparison about childhood onset OCD and adult onset OCD, because this will be useful for your clinical work. in childhood onset, what you find is that the onset is well before puberty in the childhood ages, and males are overrepresented, and they do have comorbid problems like Tick's, Tourette syndrome, and ADHD. And of course, we find that these later on do become more refractory to treatment, and that the outcomes are poor when compared to your adult OCD. OCD, amongst the most disabling of all medical disorders, it still remains underdiagnosed and treated. That is what Sivalango sir was emphasizing on earlier. It is rather unfortunate that the mean lag time, even to diagnose OCD in a particular study, is being said to be about 17 years. So, someone who has an onset, let's say around 5 or 6 years of age, you find that probably the diagnosis happens well when the person is either in his adolescence or well into the adulthood. This is quite unfortunate. And of course, the psychiatric treatment of OCD is still suboptimal. To conclude the epidemiological part, we are focusing on three things here. One, OCD per se, and the other one is OCD and related disorders, what we earlier called as the OCD spectrum disorders. And of course, the other third one, which I want to direct your attention is also there are other major psychiatric disorders in which OCS or OCD is part of the problem, like say in autism spectrum disorders, wherein the OC symptoms can be quite problematic. This is one way of looking at both impulsivity and compulsivity as endophenotypic of these disorders. Here we have grouped certain disorders under OCD and related spectrum, and of course you find that many of these features are overlapping when you consider substance and behavioral addictions, also even in disruptive and impulse control disorders like pyromania and kleptomania. Even though there are impulsive attributes to that, sometimes what you find is that this becomes compulsive acts and rituals later on. And of course, the smaller area of sexual disorders, wherein again there is persistent or repeated wrongdoings. Okay, this second section will try to look into the basic neuroanatomy of what happens in the OCD, what happens in the central nervous system in people with OCD disorders. I'm sure we recognize this gentleman. Okay, what you find is something very innocuous, okay, and everyday ordinary happening. As he keeps walking on, there is the perfunctory waving and then smiling to the photographers, and then suddenly something isn't quite right. The brain tells the president that yes, you have forgotten something, and immediately the affect changes, the smile goes off, and he stops on track, and hands automatically go to his pockets, and then you find that even he starts to turn about and start running. That's something quite normal, and something of this does happen in OCD patients, but in an exaggerated and a pathological manner. To give you a perspective of the OCD neurocircuitry, let us first organize ourselves, reorient ourselves to the structures in the central nervous system. Here you find the ventricles, both lateral ventricles and the middle third ventricle, which is again connected to the fourth ventricle. And the ventricle with their horns are being represented in blue. Okay, taking another turn, what you find is the blue colored ventricles, and of course, just immediately beneath that is what you find in the mount in the green color is your caudate nucleus, the C-shaped structure. And this is the head, body, and the tail of the caudate nucleus, a C-shaped structure. Imagine it in 3 dimension, which is just next to the caudate is your putamen, and the caudate and putamen are lying in close approximation, and you see the gap in between these two structures, wherein your internal capsule radiations are going to emanate out. And now let us look into other structures which are also closely related to the OCD pathology. For this, we'll remove the anterior part of the frontal cortex, and we'll try to have this in the coronal section. Just give me a minute. Okay, if you remove that, now you get a 3-dimensional idea about where these things are, what are the relations to them. Okay, that's the caudate nucleus, and what is being shown is your putamen. The putamen, and medially you have the lobus pallidus internus, and the structure that was shown just now. That's something which lies beneath the head of the caudate nucleus, is your nucleus accumbens. Of course, functionally this can also be divided into a ventral striatum and a dorsal striatum. The dorsal striatum basically is your caudate nucleus with your putamen nucleus, with your lentiform nucleus together will form the dorsal striatum. Whereas your nucleus accumbens along with the olfactory tubercle, which is not shown here, would form the ventral striatum. Okay, so what's happening here is that you have this is a schematic representation. You have our orbital complex, which tells that something is wrong. And this information is passed on to the cingulate gyrus, and that elicits anxiety. And this is necessary for the brain to make some corrections and to check if things have been done properly. And that is taken care by the caudate nucleus. So if you forget whether you have locked the doors, you go back, you check that's long, and then you go on with your routine work. What happens in OCD patients? This circuitry becomes abnormal. Here the major portions are the prefrontal cortex and your caudate represented as basal ganglia, as part of your basal ganglia. And in the prefrontal cortex, which is responsible for acting appropriately and genially is being maintained, and there are signals which say that these are not being maintained. These signals are sent to the basal ganglia, and this basal ganglia is responsible for the repetitive behaviors and correcting and smoothening of the behaviors. So this information passes on to the next structure of importance, that is the thalamus. This is what normally happens. So you have that something is not right or something is wrong feeling. There are multiple impulses sent to the thalamus, and the thalamus becomes excited, and it keeps on sending reverberatory signals to the prefrontal cortex in quick successions. Okay, so a lot of impulses are going to your prefrontal cortex, and again, there is a lot of repeated thoughts that this would not be done, that the hands are dirty, that you are not washed properly, and so on and so forth. That this obsessional loop starts to set in. And because of this obsessional loop, there are compulsive rituals which ensue as well. This is, I am sure you would recognize this picture. This is from Stephen Stahl, 4th edition. This depicts the bottom-up circuitry of impulsivity and reward. That impulses travel from the ventral striatum and passing on to the thalamus and then to your ventromedial prefrontal cortex. This is the ventral striatum, and on top is your dorsal striatum. So impulses go to the thalamus and then to your prefrontal cortex and back again to the ventral striatum, completing this loop. When this loop becomes hyperactive, you have a lot of excitation. This part is the dorsal striatum. The dorsal striatum sends impulses again to a different part of your thalamus. And this impulses from the thalamus reach the orbitofrontal cortex. And this loop is completed by neurons projecting back again to the dorsal striatum. We call this as bottom-up circuit because these circuits send impulses to the cortex. And what you necessarily normally happens in people is that these impulses are reduced and normalized by impulses coming from the cortices. So there is a top-down control as well. Whenever there is an imbalance between the bottom-up and the top-down control, you end up with having OCD. Here, this is again a good picture from Stephen Stahl, wherein both the ventral and striatal loops have been depicted. What researchers do find is that what initially starts as an impulsive behavior, okay, in this circuit, that is from striatum to thalamus, thalamus to ACC and VMPFC, this is impulsive behavior, and this can be either rewarded, and if the reward is positive, then this behavior is let on to continue, so that it forms a good habit or behavior. But what we find in OCD is that such impulsivity network, such impulsivity circuit becomes default, and when OCD sets in, the initial trigger is in this circuit, but later on you do find that the impulses migrate to the compulsive circuit as well, from impulsivity to becoming compulsive behaviors. And of course, they try to explain this as one other model for all your addiction and gambling and related disorders, and sometimes even to eating disorders. Why people feel compulsive to eat, either and they are okay, or even in some disorders like depression as well. Impulsivity in the former circuit is an action outcome ventrally dependent learning system, whereas compulsivity is a habit system that is based dorsally. Though many behaviors start out as impulses in the ventral loop of reward and motivation, over time, some of these behaviors migrate dorsally due to a cascade of neuroadaptations and neuroplasticity, and these engage the habit system by means of which an impulsive act eventually becomes compulsive. Now, this formulation tells that OCD sets in due to a failure of response inhibition systems. That is, there is an inadequate top-down cognitive control. From top, it's unable to control this. And as contradiction, the result of too much pressure coming bottom up from the ventral striatum of impulsivity and dorsal striatum of compulsivity. From both these circuits, there is too much impulses going on topwards, which the normal top tire is unable to control. This is a simplistic formulation of the problem. Of course, you will understand the magnitude of it when you also have to compare these other sub-circuits. Here we have depicted the reward conditioning and memory, which are handled by your hippocampus and amygdala, and these also send impulses both ways. And again, the DLPFC, the dorsolateral prefrontal cortex, which is responsible for your cognition, again sending impulses, mitigating the influences to both top and bottom tires. In the context of higher anxiety, initially when OCD starts, there is avoidance response, which gives some instantaneous relief. But the problem occurs, or the conditioning occurs, because repeatedly this keeps happening. you find that over a period of time, these rituals become a conditioned response. Again, there is an alternate formulation to this hypothesized theory. This says that OCD as habit provoked mindlessly from a stimulus in the environment. Rather than blaming the circuits, researchers do say that because the environment is something which is unavoidable, you cannot avoid dirt in the environment, you cannot avoid seeing dirt, and so on and so forth. What happens here is that obsession or OCD may in fact be post hoc rationalization of otherwise inexplicable compulsive urges. And of course, OCD patients have demonstrated lack of efficient information processing in their orbitofrontal cortex and lack of cognitive flexibility and cannot inhibit their compulsive responses or habit. Now, let's quickly rush through neuropsychology. Neuropsychological research shows that there is impairment in attention, memory, error monitoring, and emotion processing. Attention deficits in OCD can be either pure attentional deficits, potential attentional bias, and they are often younger onset patients, and you see them more severe in attention deficits in younger patients as well. Memory deficits, actual memory deficits, are they actual memory deficits, or is it only a diminished confidence in their memory? This question has also been an intriguing research area. Of course, contradictory results with some reporting episodic memory deficits, verbal memory deficits, while others have reported no deficits in OCD patients. A meta-analysis by Woods et al. Concluded that OCD patients, especially the checkers, demonstrated a memory deficit in recall, but not in recognition of verbal material. Metamemory. What is metamemory? It's nothing but our knowledge of the nature, content, and process of memory-related phenomena. Further analysis of metamemory deficit in OCD shows that this might be specific to recently experienced material than semantic memory. These are important points as we will see later. Of course, this one perceived personal responsibility has also been talked about. OCD patients habitually overestimate their share of responsibility and hence feel the need to prevent some catastrophe by means of certain rituals and precautions. This, what we call as magical thinking, also is responsible to enhance the behavior. Emotion processing, motivation, and reward system and the response inhibitions are also deficit in OCD patients. Phillips et al. Have shown that compulsive washers never feel satiated. At the same time, they act on compulsions, which are negative reinforcement. They obtain a temporary relief of anxiety, that is the reward, but they never feel full or satiated. In relation to this, search for an immediate reward, that is relief from anxiety from compulsions, lack of behavioral flexibility, and blindness to negative future consequences have all been described as characteristic traits. This blindness to negative future consequences is something significant. This answers the question why OCD people are unable to rationalize and then move over. This is an interesting study done by Cavendini et al. Using a gambling task. Here, what they gave is they had OCD patients, they had other anxiety patients as control, and a normal group. They had 3 groups, and each group was allowed to play a game of cards. They had 4 sets of cards, and each was dealt these cards from each of these sets. This is something akin to your WSCP, your Wisconsin card sorting test. The researcher gives the cards randomly from each of the set, and the player has to recognize how he is being dealt with. Initially, the player are given about $2,000 as credit, and if they get a bad card, they have to give them $200 back. Whereas if they get a good card, then they can have $50 for themselves. Now, this is interesting. The results show that OCD patients were, though all 3 of them realized that 2 of the packs in the 4 sets of cards were dealing them with good cards, when the other anxiety group and the normal group was able to use that and pick cards only from those sets. Patients with OCD were unable to do that. They repeatedly went on to take cards from the deck which were giving bad cards, and they had to give $200 back to the researchers. And this was persistent across all OCD patients. Okay, so this is the orbitofrontal striatothalamo-orbitofrontal loop, or commonly what we call as CSTC loop. What is depicted here is in schematics the orbitofrontal cortex, which sends positive impulse to striatum and then to the globus pallidus, interna, and substantia nigra complex. This is the direct pathway, which is often responsible for initiation and continuation of behavior. This in turn inhibits the thalamus, which again has reciprocal connections to the OFC. There is another indirect pathway that is from the cortex to striatum, from striatum going on to your globus pallidus externa, and then to the subthalamic nucleus, and then back to your globus pallidus interna and substantia nigra complex. This is the indirect pathway which is responsible for behavioral inhibition and switching between behaviors. And this again influences the cortex through the thalamus. So in indirect, the fault can be either in both direct pathway or indirect pathway, or in both of these pathways either. The patients are unable to stop and switch behaviors, or sometimes they have to keep on continuing that same behavior over and over again. What initially happens in obsession is that you get a short-term, there is an anxiety which you can conceptualize as short-term punishment, and this anxiety is dealt in two ways. Either there is avoidance behavior which gives an immediate reward to reduce the anxiety, or people can take up compulsions, okay, and they in the short term give relief from the anxiety. But what happens is in the long term, this becomes and goes on to strengthen the obsession, so that a loop forms in here and they are unable to break this lock. This later leads on to impairment as more and more obsessions accumulate and more time is spent in compulsions. Their daily life is impaired. Of course, there are many researchers who say that there are deficits in executive functioning. And if you look at the summary, consistent findings are memory and executive dysfunction, and emotion reward systems are deficit, and there is a complex interaction between these and the ACC. Neuroimaging studies have been done using MRI, MRS, EEG, SPECT, and diffusion tensor imaging, etc. Many of the studies do say that there is volume reduction in bilateral OFC and there is reduced volume in particular regions which are involved in OCD. And of course, there are contradictory studies which also say that there is increased volume of these structures as well. One other area which has been concentrated on is the caudate nucleus volume per se. Of course, the findings are again variable. Some say it's increased, decreased, and some studies often report normal volume of the caudate. MRI volumetric deficits in other brain areas are also have been shown in thalamus, amygdala, hippocampal complex, and superior temporal complex as well. There is a decreased OFC volume with increased thalamic volume in refractory OCD has been noted. Of course, the PET report shows increased glucose metabolism in these structural areas of OFC, caudate, thalamus, and prefrontal cortex. PET studies have alternatively found both increased and decreased blood flow to various brain regions. Functional MRI studies show that the ACC, or the anterior cingulate cortex, also plays an important role in OCD maintenance. It's divided into dorsal and rostral ACC, and Mont et al. Hypothesized that the exaggerated false error signals that are generated by the anterior cingulate cortex might underlie the compulsive behaviors. This is what that gives you this something is not right or not just right, or that sense of symmetry that goes off in OCD patients. Study by Matthias Kohls et al. Patients demonstrated significantly greater activation than controls in bilateral PMPFCs and right caudate nucleus. This study is interesting because it showed differing areas were responsible for different symptomatology in OCD, like watching, checking, coding, and so on and so on. Now, of course, neurochemical changes have been studied, and what we see is that there are a lot of neurotransmitters that have been implicated in the study. Electrophysiological studies are an important way to look into the neurobiology of OCD. Patients often show impaired response inhibition, executive dysfunction, and hyperactive sensory gating, and frontoparietal dysfunctions. A longitudinal qualitative EEG study by Bowling et al. Demonstrated abnormalities that were decreased after treatment with paroxetine in OCD patients. Of course, this is something we touched upon earlier. This is one particular subset of young males' early onset severe symptoms. You also find that thought signs are more in these patients. About 80% have tics, and pluriform movements were seen in one-third of this patient population. And there is also an increase in ventricular size. And the course is chronic, and the symptoms can be a bit refractory. There's a large body of evidence for serotonin. And of course, we know that primarily SSRIs and clomipramine are the first-line treatment for OCD disorder. SSRIs, here I just want to compare depression and OCD. In depression, when you start an SSRI, there is an initial worsening of symptoms and followed by a gradual recovery in about 2 to 3 weeks. Remember, this happens in 2 to 3 weeks. This is paralleled by the desensitization of the terminal serotonin autoreceptors that exert a major influence in determining the amount of serotonin in the synaptic clot. After 3 weeks paroxetine treatment, mouse brain slices have been taken and electricity passed and the discharges have been studied. What you see that there is an inhibition from the serotonin 1A receptor, the impulses are reduced so that there is not much of serotonin that is released in the synaptic cleft initially. And only later on, when there is accumulation of SSRIs, you find the benefit of treatment in these patients. The increase in such evoked serotonin release in OFC was found only after an 8-week treatment. In depression, you find it in 3 to 4 weeks, whereas in OCD, we do know that it takes a little longer than as treatment with depression. It takes almost 6 to 8 weeks for the OCD patient to give considerable relief from the symptoms. So the data shows that the time course for therapeutic response to SSRIs in OCD is delayed, and you do need a larger dose of SSRIs for OCD. And of course, other transmitters studied are glutamate, dopamine, and of course, in childhood OCD, it's better to give SSRIs and dopamine. Neuroimmunological studies in OCD. You look at the evidence. Let's take Sydenham's chorea, OCD in Sydenham's chorea. Sydenham's is, of course, an autoimmune disorder brought on by a streptococcal infection, wherein the cardiac is involved. And in the prototypical pandas, again, it responds to immunotherapy, and you do find that obsessive symptoms are also relieved by immunotherapy in these patients. And of late, this particular B lymphocyte antigen, known as D8x17, patients who have these are more susceptible to such inflammatory or post-streptococcal autoimmune sequelae. Genetics of OCD, it shows you that the Twing and family studies report that OCS and OCD can be inherited, and that the monozygotic concordance is about 65% to 87%, and almost half of all dizygotics do inherit the symptoms. Conflict in studies also show that both genetic and environmental factors are important for the evolution of OCD. Of late, novel genes like SAPAP3 gene and neuronal monoamine transporter gene have also been extensively studied. Towards our conclusion, just want to show you this slide. Why do we need to know all these, and why do we need to be going after these individual subcircuits in OCD? Because such circuits do offer us an insight into what would be the best treatment strategy in such symptoms of OCD. Say, for instance, if it is the sensory motor CSTC circuit involved, we do find that RTMS and PPCS are much more beneficial than others. Whereas if it is going to be your frontolimbic circuit, exposure and response prevention or SSRIs are going to be much more beneficial than others. So that's why some thought has to be given to what are the symptoms and what are the circuits and circuits of OCD. So to conclude this, there is strong neurobiological evidence for abnormalities involving various domains of brain structure, not only in functioning, in neuropsychology, neurophysiology, chemistry, and of course, neurogenetics. An understanding of these will help us in managing OCD better. But still, there's a long way to go for conclusive evidences in each of these domains. Thank you.
What seems to be a tougher thing to grasp in CV or presentation the annotated pages and something to chat with individuals, showing how this expresses impulsivity as an excellent presentations. And so we have a few questions against regarding presentations on neurobiology. Am I audible, sir?
Yes, sir, you're audible.
Can we proceed to the questions?
Yeah, if it is okay with sir, you can. But do we take questions then and there or at the end of the program?
I think we'll continue.
Because I think I have exceeded by 5-10 minutes. I'm sorry.
We conclude the questions in this.
Okay. Can I have the questions?
So, Dr. C.R. Pondicherry has asked you on DBS areas commonly stimulated in OCD, which you have mentioned. Is there any specific locations or anything specific to the anterior or the dorsal surface? Any specific areas for use of any neuronavigation techniques in DBS, anything specific like that is available? Hello. Some question clear, sir. Hello.
Hello, am I audible?
Hello, sir. Okay. Fine. Hello. Hello. Dr. Ishwaran from MGM, Mahatma Gandhi Medical College and Research Institute, Pondicherry, has questions on the areas of deep brain stimulation. So you have mentioned in your treatment implications slide.
You break. Hello.
Hello.
Yeah, hello. Arpagam, I think the question is on deep brain stimulation. Hello. Hello. Am I audible?
Hello.
Am I audible, sir?
Sir, am I audible to you?
Yeah, you are. I'm able to hear you. Am I audible?
சார் நீங்க லாகின் பண்ணி கேட்டுறீங்களா? நீங்க லாகின் பண்ணி கேட்டுறீங்களா? கேட்க மாட்டேங்குது. ஹலோ. சார் கேக்குதா?
நான் பேசுறது கேக்குதா?
ஹலோ.
ஹலோ. ஹலோ.
ஹலோ.
Hello.
கேட்கலையே சார். சார் நீங்க டேக் ஓவர் பண்ணிக்கோங்க சார்.
Arul, can you hear me?
Yes, sir.
Sorry, actually the host, he was connected and he got disconnected. So there is a lot of technical glitch here.
Yeah, it happens. Well, sir.
We were taking questions then and there only.
Okay, sir.
So I can read a couple of questions if you want. I think the questions that we received from the delegates. Is it okay if I can read it and you can respond?
Sure, sir.
Shall we do that now or?
Yeah, you can do that now, sir.
Can you hear me now?
Yeah, I can hear you. Am I audible?
Yeah, that's fine. Yeah, absolutely. I think the first question was about like we have different obsessions clinically. Is there any specific structures that correspond to different obsessions? In other words, like why would one person get one obsession but not the other? Is there any link in the brain that explains this difference?
Now we are starting to see that some of the fMRI studies just begun to show that there may be individual sub-circuits within the OCD circuits as well. Even though they are unable to pinpoint as to which are the specific symptoms in OCD, they are able to at least group those symptoms together as particular themes, and at least these correspond to the fMRI pictures that we get when we do studies in those patients. As mentioned earlier in the presentation, when we have those 3 or 5 themes, either a theme of contamination or a theme about obsessive doubts, those areas, when patients with OCD with such symptoms, those areas are found to be hypermetabolic in both SPECT and PET studies. So only preliminary information is available from these studies. Right now, we are unable to exactly pinpoint why this is, or which symptom a particular patient is going to have, or which symptomatology is going to be the major presenting symptom from any of these particular
themes. So still early days, isn't it?
Yeah, yes.
Okay. And there is another question we received from one of the postgraduates is about, is it a matter of routine that we do brain imaging for patients with OCD? What do you recommend?
No, as I said in the initial presentation, we go by phenomenology and we don't have any of the special investigations that we do.
Okay.
Most often, as per epidemiological data, even by the time they reach a psychiatrist or even a doctor with their full-fledged OCD symptoms, there is quite a lag. 10 to 12, 17 years of lag is there. So by that time, there is much consolidation of OCD in those patients. There is, I don't think there is any point in doing investigations at that point of time. Of course, the situation will be different if you get a childhood onset OCD. There you have to do most of the investigations to rule out other causes, autoimmune or organic OCDs. But in an adult case of OCD, I don't think there is any need for special investigations per se. We can start treatment and continue with that. But of course, for research purpose, it would be better to do some of these studies.
Thanks, Arul. I think probably we're coming to the end of the first session. Thanks a lot. I think the pictures that you showed us were very easy to understand, and definitely it was it's going to be eye-opener for a lot of the postgraduates and undergraduates, trying to understand actually what is going on in the brain, what areas are implicated, and how actually they cause the symptoms of OCD. So I think it's an excellent presentation from Arul Saravani. Thanks a lot for joining us. We'll move on to the next session.
Someone asked about, it was patchy, but someone was asking about DBS. Areas where deep brain stimulation are. Was that the question?
Yes, sir, exactly the areas where deep brain stimulations work. Any specific areas?
As shown in that last slide, mostly we concentrate on the ventral striatum, and the nucleus accumbens is another area. And of course, traditionally we have been doing, the anterior part of the internal capsulas.
Thanks. Thank you, sir. Thank you. Thanks for the wonderful presentation, sir. Sorry for the technical glitch in the
Yours is pretty. I think yours is much better signal there.
Yeah.
Anyway, thank you. Thank you so much for having me.
Thank you, sir. Thank you. So, okay, I apologize to the delegates and other panel members for the delay and the technical glitch. So, without wasting more time, I would like to move on to the next presentation by our in-house faculty, Dr. S. Usaid, Assistant Professor of Psychiatry in the department in Karpaga Vinayaka Institute of Medical Science. He has completed his undergraduation from Balaji Medical College and post-graduation from Vinayaka Mission, Kripananda Warrior Medical College, Salem. He owns a gold medal to his name from in his post-graduation days, and he has trained himself in child psychiatry from NIMHANS, Bangalore. I would like to welcome Dr. Usaid to speak on the topic obsessive spectrum disorders, an overview. A rainbow is usually more likable to watch than a single color, right? So now we welcome Dr. Usaid to present on the rainbow of spectrums on OC disorders. Over to you, Dr. Usaid.
Thank you, sir. Thank you very much. And I thank our HOD, Dr. Shiva Ilango, sir, and all our faculties to giving me this wonderful opportunity to speak in this CME, that is online CME. Yes, sir. Is my slide visible?
Yeah, it's visible.
Am I audible, sir?
Yes. Yeah, you're audible.
Yeah, okay, sir. Thank you. And without wasting much time, I'll proceed into the seminar. My given topic is OC spectrum disorder and overview. As Arul sir already told a lot about the OC spectrum and what all diseases are or conditions are included in OC spectrum disorders. So, in in the overview of presentation, first I'll be telling about the introduction, the concept of spectrum and history about how the spectrum concept and the OCD was evolved, and about the individual disease, conditions in last. So coming on to the introduction, first, as Sir said, OC spectrum disorders are often chronic running and debilitating illnesses when compared to other common neurotic conditions in psychiatry, and its overall prevalence is 1 to 3% in the general population, and also it varies from culture to culture, and the geographical area also varies with the prevalence rate. And high levels of social and occupational impairment is seen in people who are affected with this spectrum illness. And even though with standard treatments which are being given for all these days, nearly half, that is 40 to 60% of patients do not respond adequately or properly to the standard treatment protocols. It is thought mainly because of very complex etiological and the neurobiological factors which cause the illness. And in recent times, the improvement in neuroimaging techniques and the genetics have thrown some light over these conditions, and we are trying to know better about these conditions or the illnesses. So this has a very vital implication on the classification of even OCD and its spectrum disorders. At present, OCD is just nosologically placed and classifies based upon their phenomenologies. There are a number of clinicians who are comfortable in placing OCD in neurosis, and others like they debate that because of varying levels of insight, they debate that it might be a psychotic illness. So better understanding and classification will lead to better treatment and the prognosis of these spectrum conditions. Coming on to the history, so the conceptualization of OCD and its spectrum disorders have evolved over time. Like over last 3 or 4 centuries, there are drastic improvements in the phenomenology, treatment, and even the diagnostic parts in these spectrum illnesses. So first, when OCD was understood on religious terms, exorcism and torture were employed as a treatment options, and it was more inhuman when compared to nowadays treatment. And Esquirol was the first person to describe about monomania in 1838, which he described as a person who is chained to actions that neither reason nor emotions have originated, that conscience reject and will cannot suppress. So this was his description on monomania. On like further years, Moral described OCD as a disease of autonomic nervous system, and he labeled it as delirio emotive. Later on, Pierre Janet described how obsessions and compulsions form over time, and he divided it into phases. The first phase being indecisiveness and need for perfectionism and orderliness, which he termed it as a psychasthenic state, followed by forced agitations, where a person needs for symmetry and repeating things and checking things are noted. And in the last phase, where there are frank obsessions and compulsions. After Pierre Janet, Freud described in his legendary case the rat man and popularized the psychoanalytical explanations and the therapy for OCD. And from here, the nosology or the way we see OCD and its related illnesses changed drastically. And in the middle of 20th century, learning theories became popular, and this theories led to behavioral and cognitive therapy for these conditions. So while these learning theories were being popularized or being looked into, in parallel, there were neurobiological explanations which were being unfolded. As Sir earlier said, the serotonin hypothesis, the cortico-striato-thalamo-cortical pathways were identified so that the treatment and the prognosis of the illness was being unfolded during these years, and the real scientific approach to the illness was introduced in obsessive compulsive spectrum disorders. So as I'll just briefly tell about obsessions and compulsions, because Sir has already elaborately said about it. Obsessions are nothing but mental thoughts which are unwanted, and the patient recognizes it as an unwanted thought, but he cannot have a control over those thoughts. And compulsions are nothing but the motor actions for those obsessions. It might be actions or even rituals which are acting out behaviors for the obsessive thoughts. Now coming on spectrum concept. So to a condition to be called or to be grouped under a spectrum concept, certain conditions must have their normal, they must have similar course of the illness, similar symptoms, etiology, onset, or even the treatment strategies. So as of now, currently, obsessive compulsive spectrum disorders are closely related to OCD. So there must be either obsession or compulsion which causes distress to an individual, and those illnesses are included in the spectrum concept. In this, they either have the mounting anxiety or the excessive guilt, which gets relieved by compulsive or the ritualized behaviors. In this spectrum concept, there are a wide range of psychiatric and neuropsychiatric disorders that share the core obsessive compulsive features and form a family of related disorders. And they are broadly grouped into three groups or clusters. First one with bodily preoccupation, the next is impulse control group, and the third is neurological disorders which share the symptoms of obsessive and compulsive features. So, the first cluster, as I said, the individuals are obsessed or like preoccupied with issues concerning body sensations, appearance, weight, or the shared features. In this cluster, there are body dysmorphic disorder, hypochondriasis, anorexia nervosa, and depersonalization. The cluster 2 has mainly the impulse control disorders or the symptoms where the patients give in to their impulse and then engage in behaviors that are associated with pleasure, gratification, and arousals. In this cluster, there are trichotillomania, sexual compulsions, pathological gambling, kleptomania, and self-injurious behaviors. The last and final cluster, it contains neurologically based disorders which affect, as Sir said, the basal ganglia, and the symptom domain of which are narrow restricted interests, repetitive behaviors, rituals, and routines are noted. This includes Tourette syndrome, Sydenham's chorea, torticollis, and autism and its spectrum disorders are included in this cluster. So this is like a broader way of obsessive compulsive spectrum disorder where all these three clusters are grouped in. Next, coming to have a view about each and every disorder. Firstly, in cluster 1, the body dysmorphic disorder, which was also termed as obsession de la honte du corps, that is obsession with shame of the body or shame of the body image. It was labeled by Pierre Janet, and in this condition, the affected individual will be always have a preoccupation that there is a defect in his body, although there might be no defect or a minor defect which even others cannot identify. The affected individuals will amplify those effects, and with that defect, it will cause severe distress to the patient and will also impair their social and occupational functioning. Though this disorder has been poorly studied because of less available data, it indicates women are affected more than men, and the common age of onset is anywhere between 15 to 30 years, where people tend to give much of importance to their bodily appearance. And the cause of body dysmorphic disorder is to a large extent unknown, but stereotyped concepts of beauty emphasized in certain populations like ballet dancers, models, film actors significantly affect an individual's psychological state. And even defense mechanisms of repression, distortion, and projections are associated with this body dysmorphic disorder. Nextly, hypochondriasis, which is also known as somatic symptom disorder, is preoccupation with an idea that a person is having a serious disease or a disease which hasn't been diagnosed, and it is going to cause severe loss of life or functions to a person. And it is based on clear misinterruption of bodily symptoms. Even for a small symptom, the persons affected with this used to amplify the symptoms and present to the clinicians. And the prevalence of this is 4 to 6% in a general medical clinic. And when they present to a psychiatrist, there are like very few of them present to the psychiatric clinic. it has an equal sex ratio, and common age of onset is a bit later when compared to the OCD spectrum disorder, that is between 20 to 30 years, where most people tend to visit doctors in the late 20s, and people with this disorder usually amplify their somatic sensations and have a very low tolerance to discomfort. The psychodynamic school of thought proposed that aggressive and hostile wishes towards others are transferred into physical complaints. So, if there are hostile and aggressive wishes towards others, they get transferred into physical complaints, and the affected individual present to the medical practitioner with these complaints. Next, as Sir said, eating disorders, there are two types in it. Like one, they restrict taking food, and others, they eat more food. Both are included in OC spectrum disorders. So people with anorexia nervosa or bulimia nervosa are always preoccupied with perception that one is distressingly large despite not being so. So they tend to avoid taking food, or even if they take food, they consume laxatives or they used to forcefully vomit so that they can maintain their slim structure. And in the opposite one, that is binge eating disorder, where the people used to compulsively consume large quantities of food. And during this binging episode, many of the affected individuals feel that they cannot have control over their eating, or they cannot resist their eating. So 4 to 6% of general population is believed to have these conditions, and most of these conditions goes unnoticed. Though binge eating is very common among male genders, females are 10 times more affected than males with eating disorders. And the main causative factor is social factor, that is society's emphasis on thinness and exercise remain an important causative factor for this illness. And even there are some biological factors like increase in endogenous opioids which cause denial of hunger, or they suppress the hunger center so that the person affected doesn't feel hungry, and he doesn't feel the need for food. Now, coming to the treatment in this first cluster, or cluster A, people in this cluster, as I earlier said, they do not turn up to the psychiatrist. They mostly turn up to the cosmetic surgeons, dermatologists, or other physical trainees, or to the gym people. Mostly they undergo liposuction, implant, or reshaping surgeries as the mainstay of treatment. The people, those who seek psychiatric treatment, the psychotherapy and positive body image reinforcements remains the mainstay of treatment, reinforcing them that look and external appearance are not the key to achieve one's personal goals is more important, and the family environment should be modified. Even if the affected individual thinks that okay, it's okay for me not to be thin, or it's okay for me to live with these defects, if their family members insist them, or if they are overly concerned about their body image, the treatment is not going to get successful. So family environment should also be modified, and it has seen in certain studies that if the affected individual develops a close bond with a non-related member of an opposite sex in the form of either future spouse or best friend, these symptoms tend to get reduced. And lastly, the medical management, antidepressants like SSRIs are used to treat the negative or suicidal thoughts, and these medications must be used as a last resort. First, psychotherapy and positive body image enforcement must be tried. Coming to the second cluster, the first is pathological gambling. So it is characterized by persistent and recurrent thoughts of gambling. The person cannot resist their thoughts to gamble. Like even if they are not gambling, they'll be always preoccupied with the thought that how to gamble and when to gamble, where to gamble, and it is just the act of gambling which gives the gratification, and the winning or losing doesn't have any meaning to them. Even if they lose, they try to gamble again, and the gambling act gives them the gratification no matter whether they win or lose. As all types of gambling have become increasingly available over online platforms and even in the cities and suburbs, like all sorts of legal and illegal gambling have been increased drastically. 1 to 3% of general populations is affected, and males clearly outnumber females in this pathological gambling. And the main causes for this pathological gambling, as suggested, is inappropriate parental discipline. Either separation or death of any one parent may predispose to develop the disorder. Freud suggested that compulsive gamblers have an unconscious desire to lose, and they gamble to revive their unconscious feeling of guilt. So this unconscious feeling of guilt, when it gets revived, these individuals get pleasure and gratification, which reduces the urges or the thoughts to gamble. Nextly, coming to kleptomania, it is almost same as the previous illness. Like in this, there are irresistible urges to steal objects. No matter even they have less value or they can easily afford these objects, the people have an urge to steal objects irresistibly, and the act of stealing gives them gratification and not the value of the object which is being stolen. And in this disorder, the exact prevalence is not clear. It varies from 0.6 to 24%. So in the general population, it is 0.1 to 0.6% of people who are affected, and 4 to 24% of people are affected. Are like it is commonly seen in people who are arrested in shoplifting, and again in this group, females are 3 times more commonly affected than males. And this data, like to a greater extent, varies from cultures to culture. And in this group or in kleptomania, symptoms do appear or exaggerate during stressful situations, and it is also seen in diseases of brain like mental retardation or even with patients with epileptic disorders. Now, next, coming to trichotillomania, it is characterized by repetitive hair pulling, or they used to pull their hair excessively because they have an experience of increasing sense or of tension or arousal. So before committing this act and after they're pulling their own hair, they get pleasure or relief, which is experienced after the act. So there will be mounting of anxiety in an individual, which will get reduced by completing the act of pulling hair. So the prevalence is from 0.6 to 3% in general population, and again, females are 10 times more affected than males. And the area where they pull out their hair most commonly is from the scalp region, eyelashes, or the eyebrows. And very rarely they go in for trunks or other armpits or the genital hairs. So onset is linked to same stressful events. And one more thing is 5HT2A gene polymorphism is noted in many studies. So this gene polymorphism is linked to the trichotillomania or causation of trichotillomania. Next, coming to paraphilic and non-paraphilic sexual compulsions. So in in individuals who are suffering from sexual compulsions, they experience increasing sense of tension or arousal. In non-paraphilic sexual compulsions, the individuals feel tension, and paraphilic sexual compulsions, the individuals affected feel arousal before committing the act, and then after committing the act, they feel gratification or relief from the mounting tension or the arousal state. The prevalence, it varies among culture, and in general, there are only a small percentage of people affected, like 0.002 to 0.2% of people are affected with these type of illnesses. And psychoanalytical model suggested that people who fail to complete their normal developmental process towards sexual adjustment go on and get these paraphilic or the sexual compulsions. Coming on to the treatment for this group, because of its rareness, the treatment in this group tend to be like individual case description or the short case series. Firstly, insight-oriented psychotherapy has shown success rate to a greater extent, and some small number of studies also show that aversive conditioning and altered social contingencies have shown success, and case reports also suggest successful treatment with SSRIs, tricyclic drugs, and lithium and naltrexone, which is an opioid receptor antagonist. Coming to the last cluster, or the cluster C, where we most commonly encounter the neuropsychiatric condition. The first one of it being Tourette syndrome. It is a chronic neuropsychiatric disorder which is characterized by several motor tics. It might be it may start from the facial tics, grimacing, or other motor traits. It might spread to their limbs and lastly to the trunks. And they can also have one or more forms of vocal tics. These patients exhibit obsessions resembling OCD. That is, they perform the tics until they feel that it is right. If they doesn't feel it right, they go on continuing these actions and they stop only when they feel right. And next, in autism and its spectrum disorders like Asperger's, it is also a neurodevelopmental disorder characterizing repetitive behaviors and strong want for symmetry. They get disturbed when they are prevented or denied of these routines. If they are not allowed to do all these routines, they get to a large extent get disturbed and may exhibit violent behaviors. And they need these routines for their normal functioning. Coming on to treatment in this cluster, first it needs a multidisciplinary care, first ranging from primary prevention to medical management of complications. To a greater extent, behavior therapy and cognitive remediation had shown positive results in the treatment of repetitive behaviors noted either in autism or even tic disorders. Medications are mainly prescribed for controlling the irritability and impulsive or the stereotypal behaviors. The medication which are prescribed are usually low doses of olanzapine or risperidone, the atypical antipsychotics, and even benzodiazepines have shown better results in managing these mannerisms. Coming to the shared features among these OC spectrum disorders, firstly, as Sir earlier said, comorbidity is an important feature where an OCD patient often has a cluster of symptoms that may present during the course of illness, like it be anything, body dysmorphic disorder, hoarding behaviors, or compulsive eating, which is noted in OCD patients. Then similarities in brain circuit and neurotransmitters are noted, like the same thing. Serotonin hypothesis is involved in all these conditions, and the same brain circuitry, that is corticostriato thalamocortical circuit, is affected in most of these people who are affected with this cluster of illness, and in all this cluster there are varying levels of insight which is shared among these compulsive spectrum disorders. And these are my references. Questions, please.
Uh, Thank you, Hussein. That was an excellent presentation by you. Though rainbow has multiple shades, it's the VIBGR most people remember. So it is essential to classify them still under a cluster so as to provide an almost near to normal treatment for them and deciding on further treatment processes in them. So with this, I would like to ask you a few questions from the participants. Dr. Usha Nandini from Tirunelveli has put on a question that how has the diagnosis of OCD changed in times of COVID, where most of the population have fear of contamination and repeated washing of hands is considered the norm?
Yes, sir. So, as I first said, obsessions are ego dystonic, and nowadays it is not ego dystonic. Every person wants to wash their hands and get safe from this illness, and even the diagnosis of OCD also has an impact over it. But in OCD patient, they themselves feel that it is not right. But in today's scenario, it is the want of the day to wash hands or be in a clean environment, that is cleaning their house or cleaning their vegetables or groceries or even other things which they buy from outside.
Okay, the other question we have from Chennai, participants from Chennai, they have questioned us, with the increase of people playing online rummy and committing suicide, does pathological gambling is really an obsessive compulsive spectrum disorder or a form of behavioral addiction? What is your opinion, Dr. Singh?
Yes, like in earlier times, it was like seen as a behavioral addiction, but there is a subtle change in pathological gambling and behavioral addiction. In pathological gambling, there is no distress to either win or losing. In behavior addiction, if the person is only like conditioned to winning, or like what to say, win disguised losses. Even though if a person wins the exact amount what he has spent through internet or through other source, he gets gratified. But over here in pathological gambling, why it is considered as in OC spectrum is because of their impulse to just gamble, not for the result of gambling.
So, thank you. There was another question posted. Dr. Sanjana has questioned that are certain personality traits common in people with eating disorders?
Yes, people like the personality traits where individuals who are affected mostly have the cluster B of personalities. Either it might be borderline personality or histrionic personality in the major thing, where they give undue importance to their bodily appearance. So these types of personality, that is personalities present in cluster B, like tend to get eating disorders more often when compared to other personalities or other personality disorders.
So, okay, that is all the questions from the delegates as of now. Thank you, Dr. Sweet. Thank you for the excellent presentation. Now we shall break for break. We shall have a break of 5 minutes, and then we'll 5 to 10 minutes, and then we'll restart by 11:45 for the next session by Dr. Preeti. Thank you.
Hello.
Hello,
Sir.
ma'am.
நான் பேசுறது கேக்குதாங்க சார்?
கேக்குது மேம். ஒரு 10:45 வரைக்கும் we are having a break, ma'am.
Okay.
We'll start by 10:45, ma'am.
நான் பேசுறது வந்து வால்யூம் கரெக்டா இருக்கா?
Volume கரெக்டா இருக்கு மேம். And visuals is also fine.
It's also fine. நான் எப்போ ஷேர் பண்ணனும் சார் ஸ்கிரீன்?
At 10:45.
இப்போ ஃபர்ஸ்ட் ஸ்கிரீன் ஷேர் பண்ணிரவா வேண்டாமா?
Okay, ma'am. You can just start sharing, ma'am. I'll just introduce and then we'll continue.
Okay, sir. Right, sir. நான் இது ஷேர் பண்ணி ஒரு தடவை பாத்துறேன். ஏன்னா ஏதாவது அதுல ஃபால்ட் ஆயிடுச்சுன்னா அது கண்டிப்பா.
Okay, ma'am. You can share your first screen for check.
System preferences. Okay. Deep is ours.
Files.
What's up? Sir?
Desktop sir.
ಏನು சொல்றீங்க?
ನಾನು ತಲೆಮಿ ತೋಪ ಕೆತ್ತರಿಗೆ ಹಾಕೊಂಡು
ನೀ ತಲೆ ಕೆತ್ತಿರೆ ತುಮಿಲ್ಲ ಸಿಲೇರವ ನೀ ತನ
Hello,
Yes, ma'am.
am I audible,
I'll
sir?
just introduce you to, yes, ma'am.
Yes, sir.
Just introduce you to the participant, ma'am. Can you just stop sharing for a second, ma'am?
Yeah, okay.
Yeah. Thank you. Okay. Welcome back, dear participants. So now we move on to the most important part of psychiatry is whenever we speak about any psychiatric illness, special populations always request special mention. So now we are going to speak on one such special populations, that is the child and adolescent. OC, as evident from previous speakers, you might have known, has its onset usually in the early adolescent and childhood and gets to treatment in a later period. So it is necessary to identify this particular disorder at an earlier stage so as to help the patients. So now I welcome Dr. Preeti, who did her MBBS and MD psychiatry from Madurai Medical College. She had underwent child psychiatric training from Dr. Jayantini, child psychiatrist from Chennai, for 2 years and did her certificate course in child psychiatry from MANS Bangalore. She started Dr. Preeti's Child Guidance Center in 2009 and 10-bedded hospital in 2016. At present, more than 1,000 children are getting therapy for developmental disorders. She has given lectures in various IMAs and in more than 200 schools and colleges in and around Madurai. She has presented papers in state and national conferences. She was a speaker in 3 national conferences. She was awarded the Best Social Activist Award in the year 2013 and Best Doctor Award from Dr. TMS Seva Sangam in 2018. Appreciation Award from the Bench of Magistrate, Child Welfare Committee, Madurai Branch in 2009. Interns from Social Work Department, Psychology and Department of Nursing are regularly posted in a center for training. And now, Madam will enlighten us on OCD in childhood. So over to you, ma'am, for your presentation.
Thank you for your kind words, sir. At the outset, I thank the organizers for giving me this opportunity. Are my slides visible, sir? Are my slides visible? Hello? Am I audible?
It's not yet visible, ma'am.
Not yet visible. 1 minute,
Yes,
sir.
ma'am.
Is it visible now, sir?
Yes, it's visible, ma'am.
My video is not visible, I think so. Is it so? My video is visible, sir?
No, ma'am. So,
I think there is
video is not visible.
Visible, yes, sir. There is some problem, I think so. I will go on with my presentation.
Okay.
I thank Dr. Shiva Ilango, sir, for giving me this opportunity. And it's really a delight to meet you all people out there in this virtual meet. And the topic given to me is the juvenile onset OCD. So, from today morning, we have been seeing a lot about OCD, and being a psychiatrist dealing with children, I get a lot of clients with OCD who have the juvenile onset. So what we call as the juvenile onset is that when the OCD develops from 11 to 21 years of age, that we call as the juvenile onset OCD. And adult onset OCD usually develops after 21 years of age. There is also a subset of OCD which develops very early, between 7 to 8 years. That is called as very early onset OCD. So we should be clear about the terminologies, because child onset OCD clearly is different from adult onset OCD in various factors, phenomenological factors, etiological factors, and epidemiological factors. So we should know more about the juvenile onset OCD. So if you see that, what are the difference between the child onset OCD and adult onset OCD? First is the symptom presentation. So when a child comes to the clinician, the child actually doesn't know that the child has OCD. So the child will come with symptoms like school refusal. They can come with irritability. They can come with poor handwriting or hyperactivity, aggression. So aggression obsessions are very common in childhood onset OCD. And to an unassuming adult, when the child presents with such symptoms, the caretaker will not know whether the child is doing it willfully or the child is having a problem. And when they land to a physician, it would have come from symptoms to the disorder level. So we should know that the symptom presentation is a bit different in childhood onset OCD. And regarding the sex distribution, if you see, it is more common in males. The childhood onset OCD is more common in males compared to the sex distribution, which is both genders are equal in adult onset OCD. And the patterns of comorbidities, if we see that this disorder is more comorbid with other disorders like disruptive behavior disorders and other all types of axis 1 disorders. So with tic disorders and OCD go hand in hand in 20% of the cases. So we should be, the clinician should have everything in mind, how to approach a child with OCD, because comorbidity is the rule and it is not the exception. And in children, the insight is always variable. It can be fair or very good or absent insight. So DSM-5 has given the beautiful specifier of rating the degree of insight, which is very useful for children. And this childhood onset OCD has specific etiopathogenesis and also the familial aggregation, where we see families with OCD and tic disorders. So we should keep also that in mind. So next I'm going to, this was already told by our Dr. previous speaker, Usaid sir. So in 1903, Pierre Janet was the first who gave a description of forced agitation in a boy, who was 5-year-old, and that was the first first literature about the OCD. So in the psychodynamic perspectives, which Sigmund Freud had detailedly described, the rat man and other things which the doctor described, here Sigmund Freud says that there is anal regression and the unresolved Oedipal complex is presenting in the form of 3 defense mechanisms, which are well known. These are the undoing, the reaction formation, and the isolation of affect. So this is a very important questions which is usually asked in the PG examinations. And in 1942, it was thought that it could be a prodrome of schizophrenia, but only in 1960s and early 70s, there was groundbreaking research where clomipramine was found effective in treatment of OCD. And after that, the behavioral treatments came into practice. And in 1980s, the fluoxetine was introduced, and it was far better than clomipramine with regards to side effects. And National Institute of Mental Health gave the first longitudinal case series in DSM-3 regarding the OCD in 1989. And in late 1998, PANDAS, that is a specific subgroup, which is the pediatric autoimmune disorders associated with streptococci. So it is a different subset which Dr. Arul Saravanan clearly covered in the morning. So when a child comes to the clinician, what are the challenges? So first we can see that the child is unable to label or recognize or articulate what is happening to the child. So we should be in a very clear mindset, because when the child feels very secretive or the child says, I cannot tell that, the clinician should come forward in saying that, here children come and say what all they feel like saying to me, because I will not be telling it to your parents or anybody. Example, yesterday a boy came and he told me that he was looking uh, at things, or looking at his teacher in inappropriate ways, which caused him lot of guilt. And when looking at his mother, he felt he had sexual thoughts about that. So, and he was literally crying. But I told that I told him that so many children have come here, and we are going to see that what is this problem. This is not your thought, it is not your fault. Some chemical changes are taking place in your brain, and how we can easily get rid of all these things we will discuss. When we tell that, the child will feel a little bit comfortable. And the presenting symptoms might mask OCD, because it can be irritability, like in aggressive obsessions, because around 7 years or 7 to 10 years, children usually develop these aggressive obsessions. This is concerned about the security of the child, so they feel that somebody is going to harm me, or I'm going to harm somebody else. This is causing a lot of conflict. So they can come with irritability or hyperactivity or withdrawal. So all this we have to see. And secrecy, they will not share about the sexual obsessions, and which is very common in children. And we should also differentiate them from DARB, that is developmentally appropriate ritualized behaviors and tics, which we'll be seeing in the next slides. And we have to know that it's a highly comorbid condition, because for more than 50% of childhood OCD, they can have depression, they can have bipolar disorder, or they can have DBD, disruptive mood dysregulation disorders. So it is a highly comorbid condition. So prevalence of OCD, it was already discussed. Lifetime prevalence is 1 to 3%. And prevalence in India, this study, it was done in 2015-16 National Mental Health Survey. It has said that 0.8% is prevalence of the childhood onset OCD. And a multi-center study was done by Srinath et al. In 2005, where rural, urban, and semi-urban centers were included in Bangalore, Lucknow, Delhi, and all these places. And he also found that the prevalence was 0.4%. And the epidemiological data or studies are very limited. And I feel in forthcoming years, there will be more Indian scenario about the prevalence of OCD. So if you see that the gender and age of onset, there is clear-cut male predominance in childhood onset OCD. So if we see that in males, there are 3 peaks, that is pre-puberty, that is 8 to 10 years, early adulthood, 18 to 22 years, and late of second decade, that is the 3 peaks that are associated in male type of OCD. In females, usually it is 10 to 20 years of age. So when we see, when the symptoms occur, it is around 9.7 years. And when we are going to diagnose it as OCD, it is 13.8 years. So roughly there is 4 years difference from transformation of symptoms to disorder level. So common childhood obsessions, this we saw earlier. So there is an inside specifier in DSM-5, and the common obsessions which adults and children have are the contamination obsession, 62%, followed by the aggression part, which is 71%, 57%, because this is specific of childhood onset OCD. And next comes the symmetry, that is 34%, and then is the sexual and religious obsession. So children are usually rule governed. So they think of black and white thinking. No, I should not get these thoughts. They think like that. And so there is fear of thinking or acting in ways of displacing God, or fear of thinking or acting in immoral ways. So these are the ways how OCD starts in children. And there is also a cross-cultural differentiation in the reporting of the sexual obsession. Somatic obsessions, sometimes children will come and say that, doctor, I feel that I could not stop blinking. I feel compelled to blink a lot of times. So that could be somatic obsession. And one thing which is very peculiar in children is the magical thinking. That they think that when there is the phenomenon called as the thought action fusion. So when they think that what I think I will act, when I see a knife, I think like I'm stabbing my mother or stabbing my close friend. So that is the magical thinking. And sometimes children will say that reading a sentence over and over again so that they might not cause the death of the parent. So this is also magical thinking. So pathological self-doubting, sometimes they doubt their memories also in pathological self-doubting. So they will go on checking. So what are the common compulsions? If we see as for obsessions, contamination, the child will hand wash or shower. That is the most common, 69%. Then repeating, 52%, checking 47%, ordering 29%, counting 15%, hoarding is 7%. And there is a thing called just right phenomenon, which the child feels that there may not be obsession, but the child feels that it doesn't feel right for me. Until then, the child will be compelled to do that. So that the child can present only with compulsion. That is called just right phenomenon. And reassurance seeking. If you see this, this is a important childhood compulsion. So when a parent comes, even during our therapy also, the child will repeatedly ask, doctor, am I thinking it wrong? Is it okay for me to think like this? So repeatedly the child will ask this to the therapist and also the caretaker. Usually the very early onset children have this type of compulsions because they could not recognize this as a obsession, and they feel that something bad is happening, or it gets into their mind, and they say that somebody, I can hear my voice telling this to do, and so immediately the child will go on and tell the mother, and mother will be in extreme stress. Has my child become a sexual addict? Why he talking like this? I'm very much depressed. More than the child, the mother will be very much depressed. So we have to reassure, and we should know how to tackle the reassurance seeking, because we should discourage the child in as the therapy goes to not to seek the reassurance from the parent and also the therapist. There are some mental compulsions like praying and repetition of words and songs, which could be purely mental compulsions. The child will not know what obsession they have, but they may be having only this mental compulsions. So phenomenological subtypes and symptoms clusters were noted by Lechman et al. And he told that they were clustered into symmetry, forbidden thoughts, cleaning, and hoarding. So 4 distinct clusters were found by him, and there was no single age-related trend corresponding with any one OCD symptom. And chronological age versus a cognitive maturity. We have to see that the cognitive maturity of the child is very important, because when the cognitive maturity is low, the child could not verbalize. So we have to do a detailed IQ testing, the language assessment, the social development, everything should be done in the initial stages of assessment. And stress sensitive, these OCD is always stress sensitive, because when there is a separation among parents, or when they relocate to other places, or one of the friend goes away from their class to another school, like that, all these stress sensitive uh, um, features cause exacerbation in OCD. So when coming to the content of obsession, as I told already, the chronological age is not that important. The cognitive maturity is very important. And pre-pubertal onset, as I told, the child could not verbalize. The child will not know I'm getting this obsession, so I'm compelled to do this. So they will present only with compulsions. But in pubertal period, there will be multiple obsessions and compulsions. Pure ritualizers versus pure obsessiveness was described by Swider et al. In 1989. Regarding the insight, children less likely to have insight, and there is a range of insight which the DSM specifies. Okay. So now coming to the differential diagnosis. So when a child presents with OCD, I should think of all these things, like whether it is developmentally appropriate ritualized behavior. So Jean Piaget, he told that 3 to 5 years of age, the children, when they want to separate from their parent, they indulge in certain repetitive rituals like bedtime rituals, or wearing, most of us have done, like wearing the same shirt to the exam hall, taking the same pen so that we feel that we will pass in the exam. So all these are developmentally appropriate. It is very common, and usually children will outgrow them. And another thing is, there is no distress in the behaviors. They feel comfortable. Now, if I wear yellow color shirt, I will definitely pass. The child feels it is there is no distress. And the next is the subclinical OC behaviors. So there will be subclinical symptoms, but if we see that, they can go on to develop future OCD. And OC in the context of axis 1 disorders. So if a child presents with major depressive disorder, the child can have OC symptoms. And in the context of separation anxiety disorder, the child can have repeatedly, the child will ask about the mother, and the child, the OC symptoms disappears once the attachment figure is near the child. Thus, we can differentiate. Also in phobia, the child will have OC symptoms, but not only in the presence of the phobic nature of the stimuli. So, other OC spectrum disorders, which was described by Dr. Usai. So, they are the body dysmorphic disorder, trichotillomania, and Tourette syndrome. So, these are all the differential diagnoses, and neurodevelopmental disorders, which was also covered. So, 5% of ODD, 5% of PDD have OC symptoms. Next, we are going to see the relationship between OCD and tics. So, it is highly comorbid. We should know that. And in children, we should look for tics. Tics are very brief. We have to differentiate between a tic and ritual. So, tic, there is a premonitory urge to do the repetitive movement, but it is very brief, and it is to alleviate the urge. But in a ritual, it is elaborate. The child will tap the right hand 4 times, left hand 4 times. That is a ritual. Just flinging the arm is a tic. So ritual is done to alleviate anxiety. And atypical rituals are also there. So in tics, like breathing, staring, and all these are atypical rituals which have more of comorbidity with tics. So we have to differentiate these. Next is the sensory phenomenon. Sensory phenomenon is which the child cannot articulate, that I am getting some perceptions or some urges to do it. So it can be a mental sensory phenomenon, or it can be a physical sensory phenomenon. So it is mostly associated with tic disorders. Next is the pandas, which we saw already. 5% of childhood onset OCD have can be pandas. So what is the typical clinical picture will be? The parent will come and say the child developed OCD overnight. So acute onset of OCD development could be pandas, and the child can present with tics or impulsivity, rage episodes, and one important thing is the deterioration of handwriting, which is seen in pandas. So now we are going to the assessment part. We all know childhood white box rating scale is very useful scale. It elaborately discusses about various obsessions and compulsions. It is a clinician rated, but now there is a self-rated instrument is also available, and these are the other tools which are commonly used. So evidence-based treatment in childhood onset OCD, we know that certain reuptake inhibitors, CBT, and both. What is the evidence for which is superior? If you see, this was the very important study, POT study done in 2004. This study, 112 adolescents met the criteria for DSM-4 criteria for OCD, and in the age group of 7 to 17 years, and they were randomized for either CBT or SSRI or combined CBT and SSRI for 12 weeks, and the study found that all was superior to placebo, and successive meta-analysis also confirmed that combined therapy is more useful in moderate to severe OCD. So pharmacotherapy, it is very much limited in children and adolescents, because SSRI, we know that sertraline is FDA approved, fluoxamine is FDA approved. Sertraline from 6 years of age can be used, fluoxamine 8 years of age. And what is the thing we have to keep in mind is the black box warning, because these children will have behavioral activation, and at times we have to closely monitor them. And if the child has mild or moderate, we can go for CBT, which is also a first line treatment. So when the symptoms are very severe, augmenting clomipramine with the fluoxamine gives very good results. And at times we also add 0.5 milligram of risperidone for once the child is not showing marked improvement after 12 weeks of treatment with SSRI. So why enrolling children in CBT is challenging is that the child is present oriented. The child does not know that by doing this I can prevent OCD in future also, or what is going to happen, that the child cannot understand. And also the complaints with the homework sessions. The child will already, children are having their schoolings and other homeworks. They feel that, oh, this is extra, I cannot do like that. So, and they passively succumb to the doctor, it is better for me to wash my hands instead of to resist that and do all these things. They passively succumb, and they are less likely to realize. And their cognitive maturity, language development, all this plays a very significant role. Behavioral intervention was developed by March and Mulle. It is very, very important manualized approach to CBT. Very clear 4 steps, which is distributed across 16 sessions. This is the Wagner et al. Protocol, ride up and down the worry hill. So this are usually used in my clinical practice. So what is that is, it is divided into 4 stages. The first stage is the detailed assessment of the child, clinical assessment, developmental assessment, language assessment. Then is the family assessment. How the family members, they usually participate in the rituals. The child will ask the mother to stand and count how many times the child is washing. This is all that it becomes a family illness. So this all should be evaluated. And then goes is the treatment readiness. Treatment readiness is that the parents will be in a flux. They will be under extreme stress. They want immediate improvement. But when we start a CBT or ERP at this stage, it will backfire. So we have to first expectations. We have to ask for the expectations. We have to be flexible in reducing the expectations. Like let the child get low grades in the exam. Still, we go on with this therapy. So all that should be discussed with the parents. Next is the implementation, and then is the dealing with the relapses, which will see later. So we have to explain that obsession is causing the fear and anxiety. To relieve that, you are doing the compulsion, and there is apparently reduction in distress, but it is not so. So when the child understands it, we are taking the child to this ride up and down the worry hill manual. So this is like even a very small child, a 4-year-old who's able to ride a bicycle can clearly understand. Like, see, you are going to ride the bicycle, you are going up the hill and you are reaching the peak, then you are coasting down. So what you have to do is that when you are riding up, you have to insist that this is let the tension mount up, but it is going to go down. So automatic habituation is going to occur. So I will have a jolly ride when I come down. So when we tell like that, it is very simple for the child to stick on to this. So define and enjoy are the behavioral components, whereas the rename and insist are the cognitive components. So, and the cognitive strategies, the child should be given with a toolkit. So whenever the child feels that that this is not me, that is the OCD that is talking. So we have to externalize. We have to rational self and irrational self. We have to make the child to differentiate between the rational and irrational self. We can also make the child to say that what name, do you have any enemies? Usually children will say, I don't like that boy at all. So when they can take, we can say that you name that OCD as that name. Some will name it as villain, or adolescent can say that that is OCD. OCD is talking and not me. So like that. So you have to see whether you are going to win or OCD is going to win. So definitely they will say I will win. So they have to make up the constructive self-talk or stand-up comments like I will take charge and I will not allow the OCD to win. And restructuring, parents will usually feel that you control the negative thoughts, you go and pray, and why are you thinking that way? So all that we have to make the parents also understand, and also we have to cultivate non-attachment, and we have to tell the parents like if that is the white bear effect. White bear effect is that when we ask the child or parent to not to think about a white bear for a minute, will they be able to do? No. So that is the same thing happening. So when they want to control it, it will come again and again. So we have to clearly explain them. So phase 3 will be the symptom monitoring, because it will be individualized for any child. Then the fear thermometer, then construction of the exposure therapy, ERP, then rewarding. We will see one by one. So symptom monitoring, this is the OCD tracking sheet. So we will ask the child to monitor what was the trigger, what was the sticky thoughts which the child got, what was the emotion, so he can rate, and what was the compulsion he did to make it go away. Very young children go and tell the parents. Older children will wash it repeatedly. They feel that their thoughts are contaminated. So by washing their hands, they are free of the contamination. So this is the SUD scale. That is the distress scale from 0 to 10, which adolescent can easily graph it. Fear thermometer, the child can put on the emoticons. Like 1 is okay, very, very least, and 10 will be a very high emotional trigger. Okay, so this is an example of a child who symptom has been monitored. See, if we see that in the last part here, the child, while eating food, the child got the thought that someone she dislikes makes her feel that the food is contaminated as she is touching it. So this is one of the situation and one of the trigger. And this second one is the need to choose a dress and go out. That time she feels that she will not be correct in selecting the dress and doesn't feel satisfied. So like this, the symptom should be monitored. and they should come in the successive homework sessions. And neutralizing behaviors, we should ask, what are you doing? For this is that the child leaves the rest in the plate and the child washes the hands and asks the mother to feed her. So this, so the third scale, the child scores at 65%. And for 100%, what is the situation is that while attending tuition class, any thought or incident related to tuition sir, she feels that tuition teacher is looking at her in an inappropriate way. So she goes and washes hands, face 4 times till it thought goes off. So that is the severe form of the stress. So we have to clearly know what all the the fear ladder. So very low situation, and the fear which the child can easily overcome can be dealt with. So it can be dealt as an imaginal exposure or in vivo exposure. So therapist can model it, and the therapist can remind of the CBT techniques, that the therapist will stand by the child. The therapist should say that it will extinguish over time. So we can easily say that, see, when you are going to a swimming pool and it is very cold, that the water is very cold, and you have jumped into the cold and now you are shivering, you feel like you have to come out of it. But when you stand there, after some time, it goes off. You feel that it is not that much cold now. The same thing happens. The child will immediately get it. Okay, let me give a try. So, and the ritual modification can be, we should not say you have to stop the ritual. We can delay it or do it differently or shorten it. If the child is brushing the teeth 20 times, he can do it for 10 times or 5 times like that. And loop tape, which the child should, he can record in its own voice and he can hear it multiple times. And we have to review the homework sessions also. This is an example of the ERP monitoring form where the child was exposed and how much the child was able to successfully do it and the rating of the tension level. So family involvement is very crucial because they should recognize that these are the OCD episodes. They should ally with the child and they have to lead the child to write, and they have to let go so the child can write on its own. They should not do it for the child. And why is the, yes, you did it, and they have to reward and praise the child. So the child should rename the OCD thoughts as villain thoughts, insist on the self that I can take charge and not the OCD, and defy in the form of reduced reassurance seeking or avoidance behavior. And when the child can do all this, he can get a 10 minutes of video gaming or any other thing the child is interested to do. So these are the books which are available online also, in Amazon also they can get for the kids workbook and also the adolescent workbook. This is the very important book, best book available for children with OCD, up and down the worry hill. It is by the Wagner et al. Who had published this book. So thank you for your patient listening, and I'm happy to answer your questions.
Thank you, ma'am.
Thank
you for the excellent presentation. Very few succeed in the art of transforming theory to practice, and you are one such person who bring in enormous amount of experience in this presentation for people to understand and put things into practice and be successful in treating pediatric OCD and childhood OCD. You have brought up nicely the challenges faced by the parents, and as well as thank you for sharing the insights on the treatment approaches that is necessary for treating these patients. We have a few questions now. First question is from Dr. Usha Nandini from Tirunelveli. She has a question saying, in developmentally appropriate ritualistic behaviors, where do we draw the line? For example, if the child resists going to exam and creates chaos at home, if a yellow shirt is not available, do we take that as an OC symptom? Since OCD has a waxing and waning picture, what are the common factors that you've seen might serve as a precipitant in children and young adults? There are two questions actually. One is, what is the line that demarcates developmentally appropriate ritualistic behaviors from OCD, and the second is the precipitants in children and young adults for OCD.
Okay, so regarding the first question, as I already told in my slides, there will not be distress associated with the ritual. Like if the child will make sure that the yellow shirt is available, and he will have the distress, he may have the fear that he may fail, but when it is not available, he will try attempting going to the exams. And also the child will feel confident when the available of the yellow shirt or the particular pen. The child will be happy. There will not be any. So it is part of the normal development. They will not come to us. And the next question is that what are the stressors which precipitate? As I already told that anything, it could be a conflict between parents or parental separation or relocation to other school or home. So all these could be stressors in children and also in adolescents.
Okay. We have another question from Dr. Shiva from Chennai. He has a question like other psychiatric disorders in a child with OCD. Many occasions, the parents try to minimize and normalize the symptoms and prevent them from appropriate treatment. How do you counsel them or engage them in your treatment?
Yeah, initially there will be
parents try to normalize.
Yeah, a nice question. Initially, when the parents come, they say that kindly counsel doctor, you say that don't think all this. They will be telling everything. So when as I told, the white bear effect, when I send the child out and when I counsel the parent, I will say that this is not so. The child is not thinking, and it comes on its own. The child is extremely distressed. We should feel sorry for the child. We should help the child, and we should not be in a quick fix to settle the problem. So when we take 2 or 3 sessions along with the parents, they come to understand, and at one point of time they feel that yes doctor, I can understand, because when I say that you don't think like that, the child is becoming aggressive, he has hit me also, so I can also understand it could be a problem. So by going along with the parent, we should not say that. Some parents are always, they will say that no, such I have not heard of such things. When we show the other case sheets of children with OCD, see, this child also has this scrupulous thoughts, this sexual thoughts, all these things, symmetry. They will know, oh, okay, right. So we will go about that.
Okay.
Yes, sir.
There's another question, ma'am. Like, how do you differentiate an imaginary friend from an OCD or a developmentally appropriate?
Imaginary
friends.
Friends. Yeah, that is not OCD. That can be seen in children who have a social fear because they'll be teased or ridiculed, or they will make some awkward gestures or statements, or others may not like them. So what they start doing is that they will have imaginary friends, and that will be a form of consoling them, and that is usually that is very normal. But in adolescent, it will usually go away, and they will normally start making friends with others. And if that is not happening, when we are too much involved into this fantasy, it can go on to develop schizophrenia in future. We should be able to differentiate that.
And the question continues with food fads also. Like, do we consider them as pediatric OCD, or it's just a normal behavior?
Food fads, yes. Food fads, as I have told, that Y-Box gives 69 list of common obsessions and
can you be a bit louder, man? It's not audible.
Okay, am I audible now?
Yes, please.
Y-Box gives 69 common obsessions and compulsions, in which food fads also come, and we have to see mostly, but it is a bit rare, because common obsessions are common. The contamination and symmetry, all that are common, but we also come across such cases.
Thank you for the more insightful presentation. In fact, I had a pediatric childhood OCD, starting them on sertraline. After 3 weeks, he started developing suicidal ideation. Then we have to shift him completely on non-pharmacological management alone.
Yeah.
So that
Yes.
was an eye-opener at that time.
Yes, sir.
Thank
Yes,
you.
sir.
Thank you.
Children. One boy. When we had explained about all these non-pharmacological methods, he was able to get it, and when to his friends also, when some others develop, oh, I too had this, I tried this, so you also tried that, like that, he was able to tell them, so they get it on very well. So we have to make some efforts to put this non-pharmacological methods in children, because it is going to be there for a long time, and the child should know ways to manage it by self. Thank you.
On a personal note, ma'am, like,
Yes.
is there any studies or something which says that, like, by curtailing or reducing the OC symptoms at childhood, you decrease the duration of the illness, or you
Yeah,
prevent the
definitely.
course of-
Definitely. So studies say that CBT is one of the first line treatment. So when applied successfully, the child is able, during the stressors, the child can able to apply those techniques, and they can postpone, or many don't get the illness at all. So it has a role.
Okay, thank you, ma'am.
Thank you,
for
sir.
the more practical presentation. Thank you.
Thank you, sir.
Uh, so now, to that we move on to the final session uh, on recent advances in the management of OCD. So, as of now, we have heard about a lot of management issues and management techniques of OCD. Now, we would like to invite Dr. Karthik Thangaveru to present on this topic. Dr. Karthik Thangaveru has completed his undergraduation from Stanley Medical College in the year 2000, and Masters in Psychiatry from IMH in the year 2004. He has completed his MRC Psych in 2006 with a CCT certificate course in General Adult Psychiatry. Currently, he is a consultant psychiatrist in Nottingham Mental Health NHS Trust for the past 10 years, and is a lead consultant and a training program director. His areas of interest rest on bipolar disorders, philosophy in psychiatry, and medical education. So over to you, sir. Waiting for your excellent presentation. Thank you, sir.
Thank you very much for your kind words, and thank you for inviting me. Just want to check, can you see my slides, and can you hear me clearly?
Yes, sir. Yes, sir.
Okay. Yeah, thanks once again for inviting me. It's always a privilege and pleasure to join CME programs back home. So even though I'm currently working in Nottingham, my foundation in psychiatry actually started very much in Chennai, in Institute of Mental Health. So to begin with, just to declare, I don't have any conflict of interest. I don't have any shares in any pharmaceutical companies. So you can take my advice on medications as without any conflicts. So I thought I'll begin with this slide. I think one of your audience actually asked a question early on, and I think it's quite pertinent to perhaps take a moment to reflect on the world that we are in. And I mean, this picture pretty much symbolizes what we understand mostly about OCD, because never in our lifetime, so certainly in our lifetime, because most of us wouldn't have been around when the World War was going on, that we've been as fearful about our health or anxious about what's going on around us, actually. And it kind of almost it's kind of caused an inflated sense of responsibility, not only for our own health, but also for our family's health, but also for the wider society, actually. And I mean, to give a very typical example, when people go around without wearing masks, obviously that it kind of evokes a sense of guilt in people. And I guess, as I said before, this symbolizes what might be going on a lot in people with OCD. Only the difference is that for us, we kind of live with the hope that it will pass away very soon, whereas you can imagine patients with OCD, this goes on day in, day out for years, and understandably they feel quite trapped in this situation. So if we move on to what I'm hoping to talk about for the rest of the session today. So again, if for whatever reason, if you don't hear me clearly, obviously I'm talking from 5,000 miles away, just let me know. So this is what I'm hoping to cover today: pharmacological management, psychological management, and a few advances in treatment-resistant OCD management, particular focus on evidence for some somatic treatments. And if we have time at the end, I'll also touch upon the service implications. Now, one of the things to say is I practice in UK. Now, I have to say, UK is not kind of a forerunner in the most recent advances. Now, that's a good and a bad thing, but more of a good thing as I see it, because we have something called NICE, which I'm sure most of you would be familiar with. NICE stands for the National Institute for Care and Excellence. Now, one of the good things about NICE is it's a regulatory body, actually. And it certainly publishes guidelines for almost all conditions, not only just mental health, almost all health conditions. And the way they do that is by independently looking at the available evidence. And they have a steering committee, which again does not have any conflict of interest. But they not only look at the efficacy, they kind of clearly look at the different levels of evidence. And I'm sure people will be familiar with the different levels of evidence. And what we really want is a type 1A evidence, which is systematic reviews and meta-analysis for treatments done on some homogeneous sample. Now, if you really look at what evidence we have for most treatments, there isn't much of level 1A evidence for most advanced treatments, because it takes time for that to come through. So NICE looks at the best evidence, but also balances that with the cost effectiveness, and then produces guidelines. So some of the more advanced or fancy treatments that come out first, mostly in the United States, takes good 5 years at least to filter through into UK, actually. And I see that as a good thing, because we often jump in out of desperation to just clutch on to the most recent treatments, and then a few years down the line, you figure out that it's not as good as it sounded. So I'll kind of go through in the next half an hour or so what I have found useful in this area. I think that this has been covered very well by the other speakers, Laurel Sullivan and Dr. Said and Dr. Preeti. So I won't spend too much of time in this, but the general concept in understanding OCD, certainly compared to 20 years ago when I started psychiatry, is it's moving more towards as a disorder where there clearly seems to be a problem in the hardwiring of the brain in terms of the circuits and the neuropsychiatric underpinnings. That's not to dismiss the very important psychological basis to these disorders. But also, increasingly, we are moving towards a more dimensional spectrum model, not just for OCD, but also for a number of other psychiatric conditions, and sometimes categorizing them into a very rigid disorder and pigeonholing them doesn't really help. So I think this is important to bear in mind when it comes to the evidence base for different OCD spectrum disorders. So we often take a stepwise model, and I'm sure that's the case across the patch. Certainly for the more milder end of the spectrum, behavior therapy is seen as an important cornerstone. And within that, as has been discussed before, the exposure and response prevention treatment has clearly got a substantial body of evidence. Now, I'm not kind of completely up to speed with practice in in India, but certainly over here, it's a centrally funded health system which is free at a point of delivery for all patients. It does come with some resource implications, even though it's a well-established model. When it really comes to the practicalities of it, it really comes down to the individual areas, individual trusts, and the individual teams and the skill set of the person who's delivering it actually. So often we rely on our psychology colleagues and community psychiatric nurses who are kind of integral to the team. It's not something that is very much led by medics consultants here, but I suppose in an Indian setting, I can imagine that as a clinician, we should be really skilled up to do something from your outpatient clinics. But what we also know is it needs at least 16 hours of ERP work to make any headway in this direction. And obviously the more severe or the moderate to severe end of the spectrum, we rely on the medications, and ideally I would want to have a combined approach. Now, as was discussed earlier, I mean, despite all the evidence-based treatments, we know that about 40% of them do not respond to treatment, and even those who respond tend to be partial responders, and that has been shown in follow-up studies done 24 months after the initial consultation. So we'll spend the next few minutes thinking about the pharmacological management. Now, I have to say there isn't anything overly exciting about the pharmacological management when it comes to the recent advances in management of OCD. The mainstay treatment still remains SSRIs and clomipramine, because that clearly has got a type 1A evidence based on a number of systematic reviews and meta-analysis and pooled data. I'll go on to discuss that in a bit more detail in the next few slides. And the next step in terms of pharmacological management, we obviously rely on antidopaminergic agents. But what kind of tends to differentiate OCD management from other anxiety or neurotic conditions is the dosing strategies, the duration, and the difference in the efficacy between these medications. So this is not new stuff, and I'm pretty sure pretty much everyone in the audience would know this. I mean, serotonin has come to dominate the management, the pharmacological management of neurotic disorders, and that has remained the case and has been kind of proven repeatedly. And I've listed the medications within the SSRI groups, which has been found really effective and efficacious, both in research settings as well as in kind of clinical trials in real life. So we kind of tend to rely mostly on sertraline and citalopram as first line, and again, that's just for reasons of kind of cost effectiveness. But all these medications do have good efficacious. Now, this is something to think about in terms of the dosing strategies. And again, I've kind of pulled this table out from the study that was done by Montgomery and colleagues. Again, was kind of substantially reinforced by further studies. What we know, these are fixed dose studies, so patients get into a certain dose and stay in the same dose throughout the study. So as you can see, the evidence kind of spans almost like 10 to 15 years. And what seems to be emerging is, for example, with fluoxetine, 60 milligrams is significantly better than placebo and significantly better than 20 milligrams. And likewise, there seems to be a dose-response relationship for paroxetine as well as citalopram, not for every single SSRIs. For example, the study about sertraline does not seem to be as good as the others. What we also know is it's a slow burner case, actually. So you might have to wait much longer to see any meaningful effect with SSRIs in OCD. And I mean, the more recent evidence for SSRIs effectiveness in other conditions like clinical depression seem to suggest that initial effects can be seen within a week or two. I mean, certainly when I did psychiatry, the usual notion is it takes at least 2 to 3 weeks, whereas now we know some of the somatic symptoms improve much sooner. Whereas with OCD, it takes much longer. And there are a few studies which suggest that you may not even see benefit, for at least 4 to 8 weeks, maybe even longer. And for a decent remission, it takes even longer, actually. And sometimes you might have to persevere for 6 months at the maximum tolerable dose. And even with that, it's not everyone who achieve remission. And by remission, we talk about at least a 20% drop in the Y-box score for adults. So as you can see, only around about half of the people do show full remission of symptoms at 6 months. Again, it kind of tends to vary depending upon the settings that you're in. If you're able to put in some additional measures, combine the treatment with psychological treatments, and you're much more likely to see positive benefits. And the second line treatment, again, the good old clomipramine. We still use clomipramine here quite widely as a second line for OCD when the SSRIs do let you down. And again, without a doubt, the placebo-controlled trials show significant improvement. But it's been criticized, certainly amongst kind of patient or service user groups, for causing some really undesirable side effects, such as cognitive impairment, the cardiac toxicity. Certainly, it's much more toxic in overdose, like any other TCAs, and the anticholinergic side effects. I mean, one of the other side effects which we don't talk about much in clinical setting for all sorts of understandable reasons is a sexual dysfunction. And we know that clomipramine is particularly notorious to cause sexual dysfunction in about 80% of the patients, compared to around about 20 to 30% in SSRIs. So it's kind of lost its favor amongst patients a bit, but still very widely used. Now, this is an important way to look at the overall evidence, and I'm not sure if people are familiar with the network meta-analysis model, which has clearly come to the limelight in the last 5-10 years. It's one way of looking at both direct evidence as well as indirect evidence. So if you're not familiar with this, I'll just very quickly mention. So it kind of allows us, it's an extension of meta-analysis, but allows us to kind of pull together different meta-analysis, although there might be some kind of confounding effects from the heterogeneous aspects of the different samples in the different studies. It allows us to just hover up and have a wider view on, what are these studies and where are they conducted, what are the kind of the patient groups, and what does it show in terms of the relative efficacy and tolerability. And as you can see, most of the studies done in OCD tend to use placebo as a control arm. And again, forgive me if you're already familiar with this, but I'm sure there will be some postgraduates who may not be. So the red blobs kind of shows the size of the sample pulled together, and the thickness of the line across the two blobs indicate the number of studies that's done in that area. So, for example, most studies done in this area involves placebo-controlled and comparing clomipramine. Now, this study from Skapinakis, which was published in Lancet Psychiatry in 2016, it's a really useful one because it not only compares the different pharmacological studies but also psychological studies. So, in this picture, you can see that there are a number of studies on your right-hand side which shows the effectiveness of psychological studies, particularly the CBT. Let me see if I can move. Yeah, the behavior therapies and the combination of CBT and fluoxetine. I mean, one of the criticisms that came out of this is a lot of studies do include patients who were already on medications before they went on to psychological treatments. Now, the WL there is a waiting list because it's a bit difficult to have a placebo control arm for psychological studies. but what people tend to do is compare the profile of patients who are on the waiting list in order to get a psychology treatment. So clearly, there seems to be a good number of studies suggesting SSRIs and clomipramine still hold money in terms of their efficacy. And the third line treatment is augmentation with antipsychotics and a combination of two medications, SSRI and tricyclic, i.e. clomipramine. So I've just kind of pulled together some of the most relevant papers, the kind of number of papers looking at it, actually, number of systematic reviews. But the one that is often quoted is this one, actually, which is just a few years old now, in 2014 by Veal et al. But clearly, what it shows is it's not uniform across the board when it comes to antipsychotics and its effectiveness in treatment of OCD. Two medications that clearly has a good balance between the effectiveness and the side effect profile are risperidone and aripiprazole. And even then, you can see there are a number of studies which kind of cross the line of no difference. But overall, risperidone and aripiprazole seem to stand out as medications that could be considered for use in OCD. Okay. Now this is another meta-analysis, but this kind of was looking into the mechanisms of action for antipsychotics, and again comparing that with the effectiveness. And this is again a few years old, but it still holds value. And this kind of shows that aripiprazole, haloperidol, and risperidone again clearly demarcate themselves from the rest of the crowd with olanzapine and quetiapine. I mean, quetiapine for some reason is not really performing well here. And the postulated theory is it could be the 5-HT antagonism, but it's mostly to do with the D2 and the D3 receptor affinities, which explains why these medications might be more effective than the others. Okay. Now, moving on to some of the other augmenting strategies. Now, a couple of studies have looked into augmenting SSRIs with risperidone when people move from SSRIs. These are either partial responders or non-responders, moving on to the exposure and response prevention arm. And this is just to reiterate the point that I was saying earlier, that people who showed partial response to SSRI, who got switched on to risperidone, fared less well compared to the ones who went on to the ERP arm. And a couple of studies have looked at it and suggested that, well, you might want to think about ERP as an augmenting strategy rather than antipsychotics. Now, I kind of lifted this slide from Naomi Feinberg's studies or compilation, really. And this is more of the novel strategies. Now, it comes with a word of caution, and I've kind of put that across, that it's based on a number of smaller studies with less evidence. So we're talking about more type 2, type 3 evidence, or even type 4 evidence around case studies and open label studies for a number of these agents, because as was discussed earlier by Dr. Arul Saravanan very, very eloquently, the circuits involved in OCD clearly, it's not only just serotonin or the 5-HT circuits, but also dopamine and glutamine has got a very important role to play. So that's perhaps the reason why medications like diaptamine and other medications like memantine and N-acetylcysteine, which do have a glutaminergic role to play, have been tried, but the results have been somewhat inconclusive, actually. So it's too early to jump into any conclusion and start prescribing for these medications. In terms of the use of mood stabilizers, again, there is very little evidence other than for lamotrigine and a couple of studies looking at placebo controls and lamotrigine, which kind of seems to be working with more sodium channel pathways. Okay, so I've tried to summarize the more of the clinical guidance that we use here when it comes to treatment-resistant OCD. Now, right on top is the most important point to bear in mind, which is the diagnostic heterogeneity. So often we as clinicians, we kind of start thinking about diagnostic heterogeneity quite late in the treatment pathway when we don't get the desired effects. And I can't emphasize enough as to how important it is to have this overview right from the beginning, actually. So often, certainly in my clinical practice, I do come across a number of patients who might be at a more superficial level, present with symptoms of OCD, but clearly they would be having a multitude of other comorbidity, be it autistic spectrum disorder, which is kind of hugely prevalent in this population, but it could be eating disorders, other forms of neurotic disorders, or even an undercurrent psychotic illness. So it's important to again hover up and have this helicopter view and understand the patient from the first few consultations to know what are the areas that that they need help with. It may not be a simple case of OCD because down the line you probably will be left feeling that you missed something right at the beginning and might have to just backpedal and go back and look at that again. So I think Dr. Preeti kind of mentioned how common it is to have comorbidity. It's almost a norm in patients with OCD. So it's important to bear that in mind. And then, as I was discussing so far, the first line treatment with SSRIs, and then going on to the second and the third line treatments. And some of the novel approaches, particularly if there is a spectrum disorder, it's still very much in early stages. So I really don't want people to immediately get excited and jump in and start prescribing medications which has no more than type 3 or 4 evidence. So what we also know about the predictors of outcome is certain characteristics seem to indicate a better outcome. So again, in the last presentation, there was a question about whether treating childhood OCD can prevent adult OCD. Now, I don't know the exact answer, but what we know is just like how we have come to understand psychosis, an early intervention in psychosis results in a different trajectory, the overall outcome. Treatment of OCD early on also kind of seemed to indicate a better outcome over the period of a year or two. So we've discussed about the partial responders and non-responders. Now, harm reduction OCD, where kind of the harm factor seems to dominate their presentation, as well as the shorter duration of illness, and people who respond very well to initial treatment within the first 12 weeks also seem to have a better outcome compared to people who have hoarding obsessions or people who have more of anancastic personality traits or obsessive compulsive personality traits. So they seem to be performing much worse. The other question that gets asked here is about how long should I continue the treatment for? And I mean, as we know, there's no definite endpoint for most of our treatments, and the general rule of thumb is to stay on what keeps you well. So if the medication has resulted in good improvement, and we often kind of go by a rule of, well, let's wait for a sustained period of stability for around about 2 years, and then start thinking about maybe dose reduction or switching to alternative medications. Now, one of the other predictors of good outcome is the metacognition. I don't know if again people are much familiar with the notion of metacognition. I'll come on to talk about that in a minute. What we know is pathological metacognition predicts poor outcomes, and there's an interesting paper that was just published early this month talking about this. Okay, now just very briefly about the evidence base for the extended spectrum disorders. This is again one of the compiled slides from Naomi Feinberg, who's almost seen as the doyen of OCD management here. She's kind of put together all the evidence base for the extended spectrum disorder, and particularly highlighting the ones for more of a straightforward OCD, where there is a good level of evidence. Now, the evidence for capsulotomy, even though there was an interesting paper that was published in, I believe it was JAMA or Lancet some years ago, it was actually withdrawn because of some reporting errors. So if we can stick to the first two columns for now, which clearly has got better evidence. Okay. Well, I'll quickly run through some of the somatic treatments. And again, this has been very well described before, so I won't labor too much of time going over this complicated slide. It's slightly busy as well, apologies. But we now know the anatomical underpinnings with OCD circuits, actually. So obviously the limbic cortex and the associated cortex with prefrontal cortex, as well as more deeper structures around the basal ganglia, the anterior and the dorsal striatal pathways. And what these kind of lightning arrows show is really the focus or the targets for more somatic treatments like RTMS, but also the deep brain stimulation. Now, obviously, the difference between these two is that the RTMS can only reach up to a couple of centimeters under your skull, whereas the deep brain stimulation, as it says on the tin, targeting the more deeper brain areas. But it's far more complicated. It does come with a number of complications not widely practiced. So the good old ECT, and how does that perform when it comes to OCD? I mean, on the whole, there is insufficient evidence given the potential risks, actually. So the number of case reports, there aren't many RCTs. I mean, one of the systematic reviews that was done in 2015 seemed to suggest that if you have certain characteristics like late onset, non-depressed patients or severe OCD, then you can consider ECT. But again, there are some contradictory evidence to that as well. So further review in the same year suggests that people with affective symptoms, understandably, if you're depressed and OCD is part and parcel of your depression, you're much more likely to see a positive outcome. But that doesn't mean that the OCD responded to ECT, but perhaps the affective symptoms responded to ECT. RTMS, it's much more promising than ECT, and clearly there's less safety concern. But again, overall, unfortunately, we were having high hopes for RTMS, and then NICE, as I was describing earlier, came up with their rapid review, again revised this year, to say overall it has less evidence to put into practice. However, it has recommended further studies and research in this area. But other reviews, which are certainly the one by Rostami, which was a retrospective review, seemed to suggest that clearly there's a 30% reduction in Y-box, which in OCD world is pretty decent. And again, there are a few predictors for better outcomes in RTMS. One was obsessive, people with more severe obsessions, people with more kind of resistant factors, and as we discussed, the focus tends to be more of the DLPFC and the